Interventions with a King. Discussion and commentary based on articles from JACC, Cardiovascular Interventions.
Hi, I'm Anna Kalinich from JACC Cardiovascular Interventions. I'm pleased to be joined today by Dr. Eugenia Nikolsky from Columbia University and the Cardiovascular Research Foundation, and Dr. Fernando Alfonso from the Clínico San Carlos in Madrid. The role of blood transfusions in the treatment of acute coronary syndromes is quite uncertain. Dr. Nikolsky, in our current issue of JACC Cardiovascular Intervention, reports on the prognostic impact of blood transfusions in patients undergoing PCI in the setting of acute MI from the Cadillac trial. Dr. Nikolsky, could you please tell us about your findings?
Cadillac trial was the primary PCI trial that had two randomization arms. The first randomization arm was a stent-assisted angioplasty versus plain balloon angioplasty in patients undergoing primary PCI. And the second randomization was apixaban versus a placebo in the same study population. We specifically assessed the role of blood transfusion in this population because of growing concern of harmful outcomes related to transfusion. And in this specific population, we assessed mortality and at 30 days and at 1 year, and as well as rates of myocardial infarction and major adverse cardiac events at the same time endpoints, stratifying patients to three groups according to the receiving or not receiving blood transfusion. One of the groups received blood transfusion in the setting of severe or moderate bleeding. Another group received blood transfusion in the absence of bleeding. And the third group were the patients that didn't receive a blood transfusion. So we assessed outcomes at 30 days and 1 year, and we saw that patients that received blood transfusion had significantly worse outcomes both at 30 days and at 1 year, including mortality, rates of myocardial infarction, and major adverse cardiac events.
Dr. Alfonso, in your editorial, you comment that these results conflict with a study published by the same group several years before. Could you comment on that?
Yeah, I was very impressed by the initial study by Cadillac when they were able to provide a risk score, and anemia was identified as a major predictor of 1 year mortality. Then Eugenia did a beautiful study where, after taking into account all potential confounders, anemia was identified as an independent predictor of mortality. Now, in this new study, using this propensity score, they managed to identify a new finding, which is the adverse role of transfusion in these patients. I think this is very important.
Now, one interesting finding was the marked difference in the nadir of the hematocrits in patients receiving transfusions. Could you comment on that?
Yeah, it's quite interesting finding. Actually, in our paper, we found that it was a huge variety in the thresholds of nadir hematocrit when blood transfusion was administered. And actually, what's interesting, more than 50% of the patients received blood transfusion in the setting when nadir hematocrit was more than 30%. What's also interesting that it was a remarkable variety in the rates of blood transfusion made between European and US countries. In the European countries, the rates of transfusion were about 1.5% versus almost 4.5% in the US countries.
As a European, what do you think about that, Dr. Alfonso?
Well, I've been always surprised by the difference that some major randomized trials have been able to find when comparing US patients with patients from Europe. And in this study, the necessity or requirement of transfusion was nearly 2-3 times higher in patients in the USA. And I guess that this may be a reason to explain the findings of Eugenia.
this is something that needs to get looked at in more detail in other trials.
Sure.
And the final thing I'd like to mention is that the ACC guidelines are quite scant in blood transfusions in the setting of acute coronary syndromes and acute MI. And I'd like to get your comments on that. Do we need more studies before guidelines are made? Or I understand there are some guidelines in the European literature.
As I understand, today we don't have any threshold, any criteria to recommend transfusion, even in patients that in theory they would need that more urgently as those with coronary artery disease. However, in the last non-ST elevation MI European guidelines, the emphasis shift from the effectiveness of all this antithrombotic therapy to the prevention of major risk, and risk was considered bleeding. So I think the mentality is changing, and now physicians are more aware of the potential risk associated with bleeding and now of transfusion.
Well, thank you very much for sharing your time and your thoughts with us. Thank you and goodbye.
Thank you.